Good evening, everyone. My name is Jody Mitchell, and on behalf of WellLink Health Alliance and Thrive for Change, I want to welcome you to tonight's event, Stimulant Use and Heart Health, Reducing Your Risks. This session is part of our ongoing Opioid Consortium education series, where we invite healthcare providers, community members, families, and healthcare partners to have vital conversations about substance use disorder and its impact on our community's health. I also want to acknowledge that tonight's program is made possible by the funding from the Centers for Disease Control and Prevention Overdose Data to Action Local Grant with Cuyahoga County Board of Health. Because we are hosting this as a hybrid event, we have folks joining us both locally in the room and virtually online. We want to ensure everyone has a seamless experience. For those joining us virtually on Teams, my colleague Rachel Summer will be monitoring the chat throughout the evening. So please feel free to drop your questions or any technical issues, and she will troubleshoot from there. We are also recording tonight's session, and the recording will be posted on the WellLink Opioid Consortium webpage. So we hope you will share the recording after tonight's session. Tonight, we're focusing on a critical and urgent shift in our community. While much of the national conversation rightly focuses on opioids, we are seeing a rise in impact of stimulants like cocaine and methamphetamine and their specific, often overlooked effects on cardiovascular health. Our goal tonight is to bridge the gap between medical data and community action, providing you with life-saving knowledge and practical harm reduction strategies. To kick things off and help us understand exactly what is happening locally, I'd like to introduce our first speaker, Manreet Beulah. She is a forensic epidemiologist with the Cuyahoga County Medical Examiner's Office. Manreet is going to walk us through the critical data and current trends that we are seeing regarding stimulant-related incidents right here in Cuyahoga County. Manreet, thank you for being here, and I'll turn it over to you.
Thanks, Jody. Good evening, everyone. My name is Manreet. As Jody mentioned, I am with the Medical Examiner's Office. Just gonna forward the slides.
Let me know if you need help.
Okay, so today I'm going to talk about the changing landscape of drug overdoses in Cuyahoga County. A bit of an overview of my presentation today. I'm going to be talking about the role of the Medical Examiner's Office in overdose prevention, and then get into some of the data trends that we've been seeing. Talk about drug overdose deaths, but also supplement our data with drugs that are seized by law enforcement and also our pilot drug checking program. So as you guys know, there's 3 waves of the opioid crisis, and the medical examiner's role within this crisis is to conduct death investigations to help determine the cause and manner of death in overdoses. So from the 1990s to the 2000s, we saw a rise in opioid pain relievers like oxycodone, leading drug overdose deaths. And then we saw the shift to heroin from 2010 to 2014 due to some of the unparalleled consequences of overprescribing. And then we saw the shift to fentanyl and its analogs in 2014 to 2024. Things have shifted a bit in the past 2 years, so I wanted to focus a bit on those changes. So drug overdose deaths. Many of you are probably familiar with this graph. We share it quite a bit, but it looks at drug overdose deaths from 2009 to 2025. The bolded line at the top, that represents our total drug overdose deaths in Cuyahoga County. And you can see from 2023 to 2025, we've seen a significant dip in all drug overdoses. And that's primarily driven by decreases in fentanyl-related overdose deaths. That's the green line on this graph here. You can see that we've dropped down from 469 overdose deaths related to fentanyl to 153 in 2025. And the 2025 data is preliminary, so there may be some additional cases with that number, but that's our projection for the year. For total drug overdoses, we're projecting about 360 overdose deaths. That may change as well, but we haven't seen numbers this low since the heroin phase of the opioid crisis. So although our numbers are down, they're still quite high, affecting Cuyahoga. So here I wanted to focus a bit on the trends that we're seeing in 2025. It looks like 2025 is going to be the first year where we see cocaine as our leading cause of overdose death, surpassing opioids and even fentanyl. One of the things I wanted to highlight on this graph is our drug combinations that we see. So deaths that contain cocaine and fentanyl. About 30% of all of our cocaine deaths also include fentanyl. This is a big drop from 2023, where almost 70% of all of our cocaine deaths also included fentanyl. So we decided to look a little deeper into our 2024-2025 data because we're seeing the most decreases in those years. What we found was that there was a decrease in the number of white decedents we were seeing, comparison to Black decedents, where we're seeing an increase. We then stratified by race and sex. So we wanted to look at white males and white females. They're predominantly seeing a decrease, although the numbers for females are quite steady. We're not seeing that much of a change. And then in Black males and Black females, we're seeing an increase, but primarily in Black males. So here we decided to look at whether, when we're looking at race and sex, are there changes in the drugs that are involved in the overdose as well. So this is just data from 2025. When we looked at this data, we found that when it came to opioids, we would largely see white males with a higher number of overdose deaths, versus when we look at our cocaine-related fatalities, particularly cocaine without any fentanyl, we would see Black males with a higher number of overdose deaths. We also wanted to look at age group. So we compared age groups across race and sex, and white males made up the majority of overdose deaths between the 25 to 54 age group. However, when we looked at the 55 plus age group, we saw that Black males had a higher number of overdose deaths. We wanted to look at Black males over the age of 55 a bit closer so we could understand if there were changes in the drugs that were involved in overdose deaths. So we compared 2024 to 2025 data. That data is up to Q3. It's not fully ruled yet for 2025. But we saw large decreases in the number of fentanyl-involved drug overdose deaths. That's that first number there. But as we move to all cocaine categories that's highlighted, that generally was stable. We didn't see too much of a jump in the all cocaine category. However, when we move to cocaine without fentanyl, that's where we see the largest increase. So what we're seeing is that Black male decedents in the 55 plus age group are predominantly having cocaine without fentanyl overdoses. Some of the other drugs that we see in combination with cocaine include alcohol. And that also can create a synergetic effect of an overdose or an overamping. Now I'm going to move on to drug seizure data. So these are drugs that are seized by law enforcement that are tested at our forensic laboratory at our office. So this is a bump chart. This is a chart that looks at the top 10 seized drugs in Cuyahoga County. So I've organized them by ranking from 2022 to 2025. So the most common drug that was seized in Cuyahoga County was cocaine across all years. However, methamphetamine is moving up a bit to the number 2 spot, fentanyl down to number 3, and heroin's moving up a bit to number 4. And xylazine in the green is holding pretty steady. So the top 5 drugs that are seized usually are relatively stable. Things start to get interesting for the second half of the graph. from number 6 to 10. There we see a lot of new additions in 2025 and things that have fell off the top 10 list from 2022. We see common adulterants like medetomidine, BTMPS within the drug supply, but also we see decreases in fluorofentanyl, which is in green. It's moving from the number 5 position down to number 8. All of these trends align well with what we're seeing in drug overdose deaths as well. But we also want to compare it to our recently launched pilot drug checking program to see what types of drugs are found in drug paraphernalia. We're not at the point where we're checking drugs just yet. Right now, we're still focused on paraphernalia. Our drug checking program, or DCP, is funded through a federal grant through the CDC. So the Centers of Metro Health's overdose prevention programs are collecting used paraphernalia. About 20 samples per week is what we collect for drug testing at our laboratory. The test results are then shared out with the OPP sites. They're also shared with clients who submitted those paraphernalia. And we also have a public-facing dashboard, which I think the link will be shared in the chat. And then we also started testing pipes and cookers earlier in 2025. So we collect the paraphernalia from 7 sites across Cuyahoga County. Between the centers and Metro Health, they collect over 15,000 syringes. We just don't have the capacity to test all of them. So we test, like I said, 20 per week. So that's less than 5% of everything that's collected. So it's a very small subset. It's not representative of all the drug use that is in Cuyahoga County. But it can paint a picture of what's being used, particularly with syringes, because that's primarily what we collect. We collect both random and non-random samples, so clients can request to get their samples tested. So I wanted to share a bit of a breakdown of who served with this DCP program. About 90% of our clients are white, 56% are men. The average age is about 42 years old, and 51% of our clients requested their samples to be tested. So that's like a 50-50 split between randomly tested samples and those that are requested. On average, the samples are used once by one person. Most clients expect 1 to 2 drugs within their samples, but testing shows that there's an average of 6 substances. Now, this can range from major drugs like heroin, cocaine, fentanyl, or adulterants or sugars that are added to the substance. And our average turnaround time is 34 days. So this is a look at some of the major drugs per month that we see with our testing. The blue line at the very top is fentanyl related. It's fentanyl detected. That's the most common drug that we detect in our samples. And it's about, I would say, like 60-ish% of all of our samples. The other drugs, cocaine, heroin, xylazine, medetomidine, and methamphetamine, are sort of squished together. So I'm going to go over to the next slide so we can pull out some trends. We kept fentanyl here just to show you that that's the most common drug detected. But when we started the program in August of 2024, we weren't seeing much medetomidine in the beginning, but we were seeing xylazine at about 46%. So quite a bit of our samples. As we went on with our monthly data collection, we saw that medetomidine was sort of replacing xylazine within our drug supply. Xylazine isn't completely gone. It's still present within our supply at 26% from December of 2025. But medetomidine now makes up 50% of all of the detected samples. Trends like these are super interesting, I think, to help inform interventions for public health and overdose prevention. Another thing that we test for or we collect as a part of our drug checking program is what clients expected in their drugs versus what was detected in the drugs. So we have heroin and fentanyl, which are the most common expected drugs within a sample. And heroin can be used as a general term to include any opioid. So sometimes making that one-to-one comparison may not be accurate. So we try to loop heroin and fentanyl together. But for this presentation, I want to focus on cocaine. 93 clients expected cocaine in their sample, but 386 samples were detected with cocaine. I think that's a pretty large gap in our understanding of what's in the drugs. So you can see about 10% of clients expected to see cocaine. However, it was detected in about, I'd say like 40-ish% across the year. So I think this is another tidbit where we can spend some time to educate people who use drugs, but also providers on what we're seeing within the drug supply. Particularly syringes, this analysis focuses only on syringes. And then here, what we tried to do with this graph is compare some of the drugs that we see most commonly in our DCP data and compare it to our overdose death data. Are we seeing different trends, the same trends? So for our overdose deaths, fentanyl analogs, cocaine are the most common drugs that we see. And similar to our DCP, we also see those drugs. However, our DCP supplements our death data with the prevalence of xylazine and medetomidine. Although they may not cause fatalities, they still do create issues for people who use drugs, like skin lesions or longer time spent in withdrawal. So it's important to supplement multiple data sources together so we can have a more clear picture of drug use within our county. And then just for my final slide, some takeaways from the presentation. I know that was very data heavy. So just some final thoughts. Fentanyl-related drug overdose deaths and drug seizures are decreasing within the county. Cocaine-related drug overdose deaths are increasing by about 7% since 2024. Cocaine seizures are pretty stable. And there's an increased number of adulterants in the drug supply that we're detecting because of these multiple programs that we have, whether it's drug overdose deaths, drug seizures, or a drug checking program. And I just wanted to give a shout out to all of our partners on our OD2A grant that help us with this drug checking program. We're super thankful for everything that you do. And I will end it there for any questions. Thank you.
We have a question on the line from Larry. Larry, do you want to ask your question? I don't know if he can come off mute.
Oh, hi, this is Larry. It sounds like I heard somebody say the average number of substances present in the syringes you're testing average is about 6. But if I remember, wasn't that about 3 just like a couple of years ago? Is that a really rapid change? And if so, is the supply changing or is our testing improving?
Thanks, Larry, for your question. So the average number, when we're looking at 6 substances, that's for the drug checking program, so within syringes. But when we're talking about 3 drugs being the average, that's for drug overdose deaths. So in the deaths, there's 3. In syringes that are tested, there's 6 as the average.
Thank you for clarifying.
No worries.
Any other questions in the room? Any questions? No? Did anything stun you from this data? Yes, lots of head nods. And I asked the question online to our online participants as well, as what surprised you from this data? So please share online in the chat if you're able. We would like to collect your reactions to this data.
Thank you.
Great. Thank you, Minri. We are pleased to have Dr. Robert Bales from Cleveland Clinic South Point with us this evening to share his clinical experience on stimulant use and heart health. Dr. Bales is a board-certified family medicine and addiction medicine physician at the Cleveland Clinic, where he serves as a staff physician and assistant professor at the Cleveland Clinic Lerner College of Medicine. He also holds academic appointments with Case Western Reserve University and the Ohio University Heritage College of Medicine. Dr. Bales completed his medical degree at Thomas Jefferson University, followed by residency training in family medicine and primary care research fellowship at the University of Illinois College of Medicine at Rockford. He also holds a dual graduate degree in public health and medical science from Boston University. Thank you, Dr. Bales, for generously giving your valued time and sharing your wisdom with us this evening.
Thank you for having me. So I appreciate Mary looking at the population level data that comes out of the health department, and I'm gonna probably duplicate some of her data, but what I want to focus on is when people use these things, what happens? What are the risks, and a little bit about what we can do about it. So basically, I'm gonna go over what stimulants are and what they do. A little bit review of the patterns in Cuyahoga County, and also describe particularly the effects on the heart and the vascular system. So stimulants, to me, stimulants are a broad category of medication, including cocaine, amphetamine. A subset of amphetamine is methamphetamine. Caffeine, nicotine is a stimulant, and so is MDMA. Some are legal, available to the general public, such as caffeinated beverages. Some are legal by prescription, so we use certain amphetamines to treat things like attention deficit disorder. And then we have illicit drugs, particularly cocaine off the street, methamphetamine off the street. And there are nuanced differences between them. So some of these have, safety valves in place and some don't. I'll reiterate that this is the data out of the Cuyahoga County Coroner's Office. You can see the line indicated, and this one in purple is the sort of slow, steady rise of cocaine being found in the overdose deaths here in Cuyahoga County. And cocaine only, represents a part, but the second bar down, all cocaine is been on a significant rise. So this is a little bit complicated, but this is the human cardiovascular system. In the center, you'll see the heart with the left and right ventricle. Blood circulates through the lungs back to the heart and then through the body and up to the brain. And so this system works together to form one system. So this is more than just heart disease that we're going to talk about, but this is the system we're looking at. And this is how we deliver oxygen and nutrients to the entire body, including the brain. So what do these things do? And a lot of this is cocaine. You'll see cocaine's high. It is a major contributor to heart attacks. So we see a very high contribution of heart attacks for people using cocaine, less so for methamphetamine. We see high blood pressure, hypertension with chronic cocaine and methamphetamine use. Also, coffee at high doses can do this. So caffeine at high doses can do this. Although tolerance does build. So somebody who drinks a couple of cups of coffee a day will build tolerance and having normalized blood pressure. And we're going to talk, I have a special interest in caffeinated beverages. Stroke. In this one, cocaine is the most frequently associated. It confers a 6.4 times risk over anything else. And these are ischemic strokes. So what happens is the blood vessels clot off or clamp down, and you lose blood flow to the brain because of the stimulant effect of the, this one is specific to cocaine, less so for methamphetamine. We see aortic dissections with cocaine, but in this case, methamphetamine is the most common. So the aorta is the large blood vessel that comes out of the heart and will then act as the main distribution hub to the rest of the body. And what happens is the wall of the aorta splits. And that weakens the wall, and it's a potential for rupture, or you then can form a clot where that split is and actually clot off the aorta. And this has been seen with methamphetamine use. Almost universally lethal if it happens acutely. Pulmonary hypertension is more common with methamphetamine, less common with cocaine use. This is high blood pressure in the arteries that feed the lungs. So now we're seeing increased blood pressure in the lungs. And the lungs are actually very delicate, and high blood pressure for them causes lots of problems. So we do see this with methamphetamine. And there's a couple of references on the bottom. So to sort of put a complicated slide in front of you, we see these different pathways that all lead to aortic dissection, stroke. Myocardial infarction is heart attack. So the increased stress on the heart can lead to myocardial infarction or heart attack, where you damage or kill off part of the heart. So some of the main effects of these stimulants are, one is increasing blood pressure, a vasoconstriction or constriction of the blood vessels, and an acceleration of the heart rate. So we see the heart speed up, work harder, which increases the demand of oxygen. So how much oxygen the heart needs goes up when you're using stimulants. And there's a particular problem when you mix this with fentanyl or opiates. Opiates decrease your respiratory drive, so you have a shallower respiration. The cocaine increases the demand of oxygen at the heart level, and this is why the combination of fentanyl plus a stimulant is very deadly, actually, is you just make the heart work much, much harder in the absence of the ability to increase your oxygen uptake from the lungs. So what about caffeine? Caffeine is the most common substance consumed. Particularly, it comes in coffee, it comes in energy drinks. Coffee is about 75 to 100 milligrams of caffeine per cup. Energy drinks, 90 to 400 milligrams. And you will see a transient increase in blood pressure. You will see an increase in heart rate, particularly in people that don't use this very often, or at high doses. The concern is with the energy drinks, and you see the paper my group just published in November in Current Cardiology Reports. So we did a review looking at all the published research on energy drinks, and we did what's called a systematic review, where we systematically reviewed the literature we found, and we did find at higher doses, so things like Celsius and Rain, which are 300 and 400 milligrams of caffeine respectively, had effects on the heart where they altered the electrical conduction of the heart. And they also increased the workload of the heart. The genesis of this project was really actually quite an interesting story. One of my med students was in my office one day drinking a Rain, which they sell in the vending machines in the medical school. And he's looking at this thing and he's going, wow, there's 400 milligrams of caffeine in this. What is this doing to me? And I said, well, let's find out. So we did it's a research technique, and we got it published recently. And there are actually effects really limited to the higher dose, the 300 and 400 milligram. Or there are caffeine pills, which also can be very high dose in caffeine. Other effects, there are some positive effects of caffeine. It does improve concentration, and it improves alertness or awakeness. It can act like a diuretic, meaning it makes you urinate. It can increase nervousness or anxiety, so people with underlying anxiety disorders can see their symptoms worsen. We do see headaches in somebody who's a regular caffeine user. If you miss your caffeine dose in the morning, you can get headaches. It can disrupt sleep if taken too close to bedtime. And it can be very irritating in the lining of the stomach. So some people don't tolerate caffeinated beverages very well. So what can we do about it? Well, many studies have been done to try to come up with a sort of a parallel to what we do with opiates as a medication-assisted therapy program. To date, no medications have really bore that out. And there has been many trials. What really works is cognitive behavioral therapy and contingency management, which are the basis of what we do in addiction treatment centers. And the way I sort of teach this when I'm teaching students is I say, the therapy is the treatment, but the medication controls the withdrawal symptoms to allow the treatment. We would like to get to there for the stimulants. We're not there yet. So right now it's therapy and avoidance. I would like to shout out to Cardio Ohio. So this is a group I work with. I publish content on the Cardio Ohio website. This is a group that's funded by Ohio Medicaid services across the state and has lots of topics on heart health, from pagers to full-on podcasts. Here.
All right, thank you. Let's just taking some notes. Thank you, Dr. Bales. Are there any questions of Dr. Bales? Everyone's taking.
An article available online to read,
My paper?
Yeah.
Yes.
Okay.
Yes, you should be able to find it
just by the title.
by the title. Mhm. Sir?
I had a question about caffeine. Is all caffeine created equal, or is there anything about the differences in bioavailability or metabolism of, say, caffeine from coffee, tea, or energy drink?
So caffeine is caffeine is caffeine. The dose matters. So tea is going to have the least amount. Coffee will be in the middle, energy drinks on the higher side. There's also other things they add to energy drinks like taurine. So those may be playing a role. Tea and coffee also have some antioxidant properties. So there is other benefits of those products. Unless you do the double whipped latte with 4 packs of sugar at Starbucks, and then that becomes diabetes in a cup. But the caffeine itself is caffeine is caffeine is caffeine.
Any questions online? I'm not seeing any in the chat, but I don't know if hands are raised. If you have a question online, can you come off mute and ask your question?
I see Samantha Holmes might be typing something. I don't know, Samantha, if you wanted to just come off mute and chat.
Sure, I don't mind. Thank you so much to both presenters. I think my question kind of overlaps for the two of you. For Dr. Bales, I'd say my question is, can you provide any insight about heart health interventions that might help to offset the concerns you just noted about caffeine and maybe other stimulants for those who are still living with substance use? I'll be transparent. I did attend the training that you did for the Adams board previously. I think that might have been, yes, you
Couple years
talked
ago.
about, yes, you did. You talked about exercise assisted treatment. So I was wondering if there's been any more research on that.
I haven't seen research as to exercise and stimulant use. I mean, number one would be stop the use. And I know that's very difficult to do, and there's those of us that can help people. There are certain drugs to avoid, and this may be more theoretical, but certain of the blood pressure drugs, the ones that we call beta blockers, they can cause the cocaine to have more adverse effects. So there's really not a whole lot. I mean, the other thing I always worry about is a lot of people who are using opiates, using marijuana, using, name your substance, are also using tobacco products. So they're kind of double hitting their heart with the tobacco products.
Any other questions? We have one more speaker. Go ahead.
Yeah, so
so what you're saying is there isn't really, if someone came in that was using cocaine, for example, and showed high blood pressure consistently, there wouldn't be any blood pressure meds you
No,
could
no, there are blood
There
pressure,
are.
but you have to be careful which ones you pick.
Which ones? Okay, all right.
Yeah, no, we can control the pressure. It's just, you want, like, something like clonidine is better than a beta.
Okay, so that is something that someone could.
So it's important to have that conversation with your provider.
Mhm. Yeah.
Yeah.
Absolutely.
Any other questions before we move on? Well, thank you,
Thank
Dr.
you.
Bell.
Thank you.
So our last speaker is Bethany Roebuck. The Northeast Ohio Opioid Consortium is partnering with Thrive for Change on tonight's important conversation. And I'm going to turn it over to Bethany. She's deeply committed to meeting people where they are and addressing health disparities that impact people who use drugs, people experiencing homelessness, and other marginalized communities. Drawing from years of hands-on street outreach, Bethany will share some real-time insights from the front lines, highlighting emerging trends, gaps in systems of care, and action steps for reducing risks and saving lives. So Bethany, I'll turn it over to you. Thank you for your partnership.
Thank you, Jody, and thanks so much for partnering with us on this. Good evening, everyone here and online. I'm so grateful to be here. I want to start off by sharing that I'm not an expert on this topic. I'm here to share what I have learned, and it's something that I hope that we can continue to learn about together in this room by questions you might have, and I definitely learned a lot already from our previous presenters. This is a topic that honestly people who are experiencing negative effects from stimulants and particularly cocaine in our community has been happening for a long time, long before I was doing this work. But it's kind of been lost in the conversation, especially with the spike in opioid related deaths the last couple of years. More than a couple of years. And I'm really excited to bring this to the forefront. I'm not excited about how we're seeing this increasing in the community, obviously, but I'm glad that we're here to talk about it. And hopefully this can be a start to spreading the word. And what I want to talk about is more practical steps that people can use if they have loved ones that are using stimulants, if they themselves are using, or if they come across someone out in the community. As Jody mentioned, Thrive for Change does a lot of street outreach work. We're a harm reduction organization, so that basically just means we meet people who use drugs where they're at with radical love and support through a peer-to-peer model and try to support any positive change that individual can make towards being healthier and thriving. And tonight, I'm going to cover what overamping is. This is a term that maybe some are familiar with, some may not be. It's a term that we in the harm reduction and some in the drug using community use to talk about when someone experiences negative effects from a stimulant that can be overwhelming or distressing or dangerous. They come from, we already talked about the different stimulants, crack, cocaine, meth. Using the word overamping helps differentiate from an opioid overdose since they are different, and I'll go through those differences in a second. But basically, it kind of goes beyond like the high or desired effect that someone might have from a stimulant. When people talk about overdoses, they're often thinking about the respiratory depression, usually caused by opioids. And it's important that we know that people can overdose from a stimulant. I even saw in a comment online when we did an ad for this training that someone said, my buddy said that you can't overdose on a stimulant. So we're here to change that narrative. It's just, we like using a different terminology because it isn't always a life-threatening crisis. Someone might just need a little bit of time and support. And unfortunately, there is no antidote. Like we have naloxone for opioid overdoses. We don't have a naloxone substitute for a stimulant overdose or overamping. I will say that, as has been highlighted, we are still seeing fentanyl contamination in the drug supply. And so carrying Narcan is always great. I think we have a link that Rachel can share in the chat where anyone can order Narcan for free on our website. We have some with us tonight. I think everyone who's in this room has some, but we also recommend fentanyl testing strips for people using stimulants and all sorts of drugs. When it comes to the signs and symptoms of overamping, this can really vary. And someone can have one or multiple of these symptoms. There's mental symptoms and there's physical. I realize I have my notes here and I'm not using them at all. There's mental and physical. So mental symptoms can be confusion, restlessness, hypervigilance, hallucinations or delusions, paranoia, agitation, increased aggressiveness or suicidal ideation. Some physical symptoms can be jerking movements, unable to stay still, chest pain, irregular breathing, high body temperature, passing out but still breathing, uncontrollable teeth grinding, and fast racing heart rate. Some of these signs and symptoms could be the sign of something else if you were to come across someone in the community. They don't always mean that drugs are involved, but knowing that that could be the case could help you respond and ask the right questions. Now, overamping can also be caused by a lot of different things and situations. It can be a high dose, especially if someone has a low tolerance from a time of abstinence, like when people are released from incarceration, that can really increase the risk of overdose or overamping. Lack of sleep, especially when using for multiple days in a row and not sleeping. We see this a lot with people experiencing homelessness. Folks don't feel safe in their environment to sleep and are at risk of their stuff being stolen or being physically assaulted. And so they will use stimulants to stay awake. And often that happens for multiple days if they don't find someplace safe during the daytime and can't come down from what they're using. We've even had folks that like their drug of choice is opioids, but they use the stimulants to stay up at night. Setting an environment can also make a difference. If people are distracted from an unsafe or chaotic environment, they're not paying attention to what they're using or how they're using it as much, can increase the risk. Or drug combinations. We talked a little bit about that in previous presentations, as well as route of use. So if someone is injecting, that goes into the bloodstream really rapidly, whereas other routes of use, like eating a drug or something like that, might be less quickly into the bloodstream. Also, physical health. If somebody already has high blood pressure, adding this to the mix can increase their risks. But there are practical tips and ways that individuals can prevent overamping. Like Dr. Bale said, it'd be nice if we were just like, oh, they can just stop using the stimulant. But that's not practical for everyone and folks with substance use disorder and a dependency. So we like to see how we can reduce their risk. So some things that we want to educate folks on are getting enough sleep, taking breaks, changing locations if they can find a safer location, staying hydrated and eating, limiting combinations of drugs, and paying attention to dosage or doing a test dose. We have no idea what is in our drug supply, but thanks to the centers and the medical examiner Metro, we are starting to learn a little bit more. But doing a test dose can help people understand the potency, purity of maybe of what they're using before they go forward with their normal amount. Changing routes of use, like I already talked about, and understanding their individual heart health risks and other health risks. So those are the ways that we can prevent overamping. But what do we do when we come across someone, or maybe we're the one who's in active use, or we have a loved one who's in active use? What do we do to respond in that moment? First is recognizing that it's happening, and the shared language around overamping will be helpful as we try to build awareness about that, because that helps give people language to describe symptoms that they're experiencing or that they're witnessing. We'll talk about assessing whether it is life-threatening or just something that needs care and monitoring. And so after that determination, you need to decide, okay, do I need to call 911 or provide opportunities for rest and support? Most often, if we're not seeing signs of a heart attack or stroke or seizure, someone just needs that rest and support, grabbing a glass of water, getting in a new environment, maybe taking a shower. We'll get into that in a moment. So non-emergency symptoms can be confusion, panic, hallucinations, paranoia, agitation, or suicidal thoughts without action. Emergency symptoms can be the signs of a heart attack, crushing chest pain, worse chest pain with movement, signs of a seizure, overheating with a body temperature of over 104 degrees, stroke, or loss of contact with reality or psychosis. And when I look at these symptoms, I think back to, I'm actually really glad Larry is on the line. We had a situation last summer where someone showed up at our service hours that already experiences some hallucinations and paranoia on, like, that's their baseline. But that day, it was a really hot day. It was 90 degrees. This is someone who uses stimulants regularly. And he was really, really not present with us, and really seemed like he was panicking, a little bit agitated. He was sweating profusely. And we started off, giving him water. Well, we gave him like some hydration water, like Gatorade and a snack, and started to try to kind of assess what was going on. And even with the hydration, trying to cool him down, it really was not helping. And he was actually throwing up. So we saw like signs of heat stroke as well. And it was clear that we needed some extra support. We actually ended up calling in Larry to help assess the situation because he's done a lot of mental health crisis support. And it ended up that person needed to go to the emergency room. So we did all the things. We assessed, we made sure this was an emergency, but there are also other options if people aren't in medical crisis. We definitely would encourage folks to try to support the person without having to involve authorities, but also understanding that you also want to cover your bases. So there's 24-hour suicide prevention line in the zip codes 44105 and 44102. There is a care response team. And so those can be great options if you just want to make sure.
988.
Yeah, 988. It's on the slide, and everybody has a different comfort level responding to situations. It's always better to be safe than sorry. So when it is an emergency and you need to call 911, we encourage folks to just state the symptoms that they're seeing, the effects that they're witnessing, not necessarily mentioning overdosing and overamping. We know that police can be stigmatizing towards people who use drugs. We recommend that anything you can do to prevent a police response and more of an EMS response, that is what you're trying to do when you're talking to the operator. And then once the paramedics arrive, let them know all the context that you can so that they can best respond to the person. While help is on the way, providing first aid, it really varies depending on the situation, because with a heart attack versus a stroke versus a seizure, there's different ways that you can help someone. I meant to highlight this in the beginning. Most of this whole presentation comes from a resource from Next Distro, which is a national organization. It is the QR code that's been on the bottom of like every slide. And it goes into a little bit more detail on those medical emergencies and some kind of small do's and don'ts. A key thing that we always tell people, though, is to never leave a person alone on their back. If you need to step away, put them in the recovery position, which is demonstrated in the image here. For non-emergency care, already touched on some of this, but if someone is not showing any chest pain, any signs of a stroke, anything extreme, maybe they're just a little paranoid, a little bit overheated, and panicky, there's some things that you can do to support this person. You can help them cool down. So you can put like ice packs in the armpits, give them hydration, drinks like Gatorade, or if you have a hydration packet, we keep those in all of our like overdose response kits now. Give them a snack, encourage them to rest, maybe take a shower to reset, change their environment, do some deep breathing exercises with them, offer some sort of physical contact if they're comfortable and you are. And then there's also different supplements and medications that have been shown to help counteract the negative effects of Next Distro. I won't go in depth on them, but they are in the Next Distro printout. Some of them are used more in the clinical setting, but also have been known to be used in the drug using community in situations. After you respond to someone, it's important that you take care of yourself. So oftentimes in overdose response training, what happens after the fact is a little bit missed. And for responders, we always recommend, like, this is a really intense emergency situation. So don't hesitate to debrief with someone, whether it's a professional or a friend. Rest yourself as, you know, kind of the adrenaline wears off. Practice self-care if that means taking time off work or some other form of self-care that you practice. For individuals impacted and actually were the ones experiencing an overamping situation, rest, hydration, food, and of course, doctors' follow-ups if they ended up needing to seek medical care. There are awesome local resources for people who use stimulants. There's harm reduction programs like ourselves, Thrive for Change, the centers, and Metro Health. There's also low barrier treatment programs. I just listed a few on here that I know that we've referred folks to. The centers has contingency management, right? No, they're working on it. Okay, all right, we have someone of the centers in the room. But I know that Dr. Bales mentioned that that can be really helpful for folks who are wanting to move towards recovery. And there's also peer support programs where someone who is in recovery walks alongside someone on their journey. So how can you take action today? There's a lot of different ways. You can share this information with your personal or professional community. Ask them if they've heard this term over amping and how they would respond to somebody. They can watch the recording of this webinar. You can ask us to do a training with your community if you would like. You can get involved, volunteer, and engage in local efforts and continue learning. This was really just a overview. There's so much more you could get into here. Mental health first aid, I know, has really helped me in responding to folks, especially in like psychosis and other situations of paranoia and intense mental health challenges. We also, Thrive for Change has a free harm reduction 101 webinar on March 17th at 6 p.m. That folks can register for free. And we talk a little bit more about the work that we do and opioid overdose response. So thank you all so much. And I'd love to answer any questions that people have. I think I went too far.
It was just thinking to me.
Yeah.
Any questions of Bethany?
I have a question, Sherry.
Sure, yeah, go ahead.
Okay, so where does alcohol fall into overamping? Like if somebody's drunk and not having a good time, would that be considered overamping?
So overamping is specifically describing the stimulant effect, but
Gotcha.
overamping, well, using stimulants and alcohol can have a combined negative effect. And I feel like maybe Dr. Bales knows this better than I would, but the depression of the system, like a depressant and a stimulant at the same time.
Curious,
Yeah.
like I know alcohol's a depressant, but
Yeah.
I've been around tons of people who are just straight up not having a good time when they're drunk. So.
Yeah. And alcohol and cocaine combined can create, what is it called? There's a new cocoethylene in the system, which combined can have some pretty serious effects.
Are there any questions online? You can come off mute and ask your question.
A question from, or a comment, I guess, from Samantha. Thanks for sharing about the effectiveness of contingency management for stimulant use disorder.
Yeah, absolutely. I think that treatment programs are having to adapt a lot more now, from what I'm hearing.
Okay, we have another event coming up this Saturday with Project White Butterfly. They host free community dinners. We are going to be joining them on Saturday with our Igniting Compassion documentary. It's an award-winning documentary about stigma related to substance use disorder filmed right here in Cleveland. And so we're going to take a few minutes to watch that documentary and have a Q&A session on stigma at the Project White Butterfly Community Dinner. So we hope you will be able to join us there. The consortium also recently launched a speakers bureau. And so this is a place just that we can connect people who need speakers on a variety of topics, including harm reduction, stimulant use, whatever your needs are. We will help find a local expert that can come and speak to your organization or your group. So we have this on our website. If you're looking for a speaker, you can send us an inquiry through the site. If you are a speaker or an expert in an area and have a presentation that you would like to give, you can also register to be part of the Speakers Bureau. And the consortium's just facilitating those connections. We also put out a monthly newsletter called the Consortium Chronicle. This newsletter highlights local updates, state updates, federal updates from a policy perspective, as well as clinical training opportunities and education like this evening's event. So if you're not already on the listserv, you can scan this QR code and sign up to get our monthly newsletters. We also recently did a report last summer on understanding the experiences of people with lived experience that use opioids for chronic pain. We know that sometimes the dependency on opioids can start with just a chronic pain scenario. And so we had focus groups where we learned from individuals, and we are trying to inform clinicians and have that dialogue between those with lived experience and the clinicians caring for them. So that report came out. It's available on our website. I do have copies back in the back table if you're interested in that report. And we're constantly looking for more individuals with lived experience to share their story with us. So if that interests you, Rachel's email is there on the slide. We would also like you to take a few minutes to scan this QR code. This is our feedback form. Since we are funded through a grant, we all have to report on the success or the interaction and engagement from our events. So your feedback is really important. It also helps us as we create future programming. We're really interested in what you have to say. So if you don't mind, it's very important to us if you take a few moments to fill out those surveys. Are there any final questions, comments, any announcements by any of the folks participating? We welcome your feedback. Okay, I'm not seeing any. We also have just a quick save the date for WellLink Health Alliance hosts a community health conference called Connect NEO, and that's coming up on May 14th. Okay, last questions, comments. The folks that are on the line are missing some healthy snacks and resources here in the room. So when we're ending here, we're going to enjoy it. We appreciate all of your participation. We hope you found this very informative. Again, we have recorded this session so that we can share it out with others. That recording should be live next week on our website, and we'll be sending that out to folks. And for the folks that are online, we will send out the slide deck that was shared tonight so that you have that as well. All right, well, seeing or hearing no other questions, we will go ahead and adjourn for the evening. And we again thank you so much for your participation.